Spinal anesthesia for cesarean delivery. This lecture will be divided into 6 categories. Why spinal anesthesia is the best option, when to rather do a general anesthetic, what are the complications associated with spinal anesthesia, how to monitor for early detection of these complications and how to manage them, what drugs are we using for spinal anesthesia, and how to safely do an anesthetic. Just a quick recap of what was said. Why is spinal anesthesia a good idea for cesarean delivery? The pregnant patient is at risk of a difficult airway. Pregnancy is associated with changes in the airway. Lung volumes are decreased because of the gravity uterus that is pushing the lungs upwards. The oxygen stores are then decreased. The oxygen consumption is also massively increased to maintain oxygen supply to the fetus. The demand for oxygen is thus increased while the supply is decreased. The patient can become hypoxic very quickly, and there is no time to struggle with a difficult airway. The pregnant patient is also at risk of aspiration due to the increased pressure on the abdomen and the lower esophageal sphincter that is relaxed. Another important benefit is that the patient can be awake during the birth of their baby, and this will increase bonding. It's also an excellent form of analgesia. Volatiles and IV drugs can cross the placenta and influence the baby. This can cause depression of the neonate. Spinal anesthesia also decreases the risk for venous thromboembolism and infection. Remember though that your motivation for doing a spinal must be because it's the best for the mom and baby, and not because it's the only anesthetic that you are able to provide. When is a spinal anesthetic contraindicated? Whenever we talk about contraindications, we always talk about absolute contraindications and relative contraindications. Absolute contraindications are those that are non-negotiable. Relative contraindications are those that are contraindications but where a risk-benefit analysis can be done if a general anesthetic is deemed to be riskier than the perceived risk of a spinal anesthetic. Inability to rescue the patient. Even if a spinal anesthetic is planned, you still have the risk that anesthetic needs to be converted to a general anesthetic. You may, for example, have a high spinal or a patient that becomes unstable. You need to be able to intubate and resuscitate such a patient. Hypertension. The most common side effect of spinal anesthesia is hypertension. In a patient who is already hypertensive, the added hypertensive effect from the spinal may cause complete cardiovascular collapse. The most common causes of preoperative hypertension are dehydration and antepartum bleeding. These patients need fluid resuscitation even if a general anesthetic is going to be done. All cardiac cases should be referred to a higher level of care. Hypercoagulation. The risk of an epidural hematoma is increased in patients with clotting abnormalities. In patients with thrombocytopenia, the platelet count should ideally be more than 75. In cases where performing a general anesthetic would be particularly risky, the case should be discussed with a specialist to determine if the risk of performing a general anesthetic outweighs the risk of an epidural hematoma. For patients on therapeutic clexane or high-dose clexane, you must wait for 24 hours after the last dose. For patients on prophylactic clexane or low dose, a spinal can be done 12 hours after the last dose. The INR must also be more than 1.5. Local infection at the site. The spinal needle comes into direct contact with the meninges and the cerebrospinal fluid. Infective material that adheres to the spinal needle is tracked into the central nervous system. This can result in meningitis or abscess formation within the central nervous system. All patients with raised intracranial pressure should be referred to a higher level of care. Known hypersensitivity to local anesthetics. A small percentage of patients are allergic to local anesthetics. Do not disregard a claim of local anesthetic allergy. Patient refusal. Most patients that refuse spinal anesthesia simply haven't been counseled properly. It's important to give the patient all the facts, including the benefits of spinal for mom and baby, and the risks associated with a general anesthetic for both. The patient has autonomy, and if she still refuses after proper counseling, a general anesthetic must be done. Relative contraindications. All patients with active central nervous system diseases should be referred. Patients with previous lumbar surgery may have scar tissue, and a spinal anesthetic may be technically challenging. Uncooperative patients, especially teenagers, primary herpes infection. Patients with a BMI more than 40 should not be done at the district level. Refer those patients to a higher level of care. Complications associated with a spinal anesthetic. Hypertension is the most common side effect due to the vasodilatation below the level of the block. Its effect can be partially mitigated by intravenous fluid co-loading and by running a prophylactic phenol infusion. When hypertension does occur, it needs to be treated actively with the use of phenylephrine boluses and intravenous fluid. An important message is to always make sure that the patient has adequate blood pressure before the surgeon closes the abdominal cavity. This is to ensure adequate hemostasis. Bleeding may be missed if the blood pressure is low. Nausea and vomiting is due to hypertension and usually resolves after the treatment of hypertension. Pruritus may occur due to the addition of fentanyl to the spinal mix. A high spinal occurs when the level of the block rises above T4. It results in profound hypertension, bradycardia, and difficulty breathing. It can rapidly lead to loss of consciousness and even death if it isn't rapidly treated. Protective measures include a slight head-up position, keeping to the lower volume of local anesthetic that is recommended in pregnancy. Avoid injection during contraction, and avoid high pressure while injecting. Use a 5 ml syringe instead of a 2 ml syringe if possible, and inject the drug slowly. Prompt action is needed as a high spinal is a dire emergency. Always call for help. The respiratory and cardiovascular systems need to be supported by following the CAB principles. The blood pressure must be increased as soon as possible. If the patient has difficulty breathing or swallowing, she needs to be intubated and ventilated. Don't use cardiac depressant drugs for intubation. Post-dural puncture headache is a result of CSF leaking through the hole where the needle pierced the dura mater. It typically is an occipital frontal headache that is worse in the upright position. The size of the hole can be decreased by choosing the smallest needle and using a pencil point needle instead of a cutting needle such as the Quinky. It is a diagnosis of exclusion, and other serious causes of headache must first be excluded. The patient should be referred to an institution where these other causes can be excluded and where post-dural puncture headache can be managed appropriately. The law requires you to get the patient's consent before doing any procedure. Consent from anesthesia is separate from consent for surgery. The risks and benefits of both spinal and general anesthesia should be discussed. Remember to inform the patient that a spinal may fail, in which case a general anesthetic will be necessary. Consent the patient for blood transfusion. Always respect the patient's decision. Written consent is needed and should be clearly documented and signed by both the patient and the doctor. The spinal level required for cesarean delivery is T5. We cannot do a spinal at T5 as the needle will damage the spinal cord. We therefore use bupivacaine, to which dextrose is added to make it heavier than CSF. This hyperbaric mixture is injected in the lumbar area below L1 where the spinal cord terminates. When the patient lies down, the heavier local anesthetic will move into the thoracic kyphosis and block the thoracic levels. The dose of hyperbaric bupivacaine is 10 milligrams, which is equals to 2 ml. Fentanyl in a dose of 10 mics, or 0.2 ml, is added to the bupivacaine. The total volume that is injected is 2.2 mils. Hypertension is a very common side effect of spinal anesthesia and must be treated aggressively. The first-line drug of choice is phenylephrine. It is given in doses of 50 to 100 microgram until the patient is normotensive. Can be given as a prophylactic infusion of 25 to 50 mics per minute, and the rate can be increased or decreased based on the blood pressure. Phenylephrine causes bradycardia. In such cases, atropine should be given to increase the heart rate, or it should be substituted with ephedrine or even adrenaline. Ephedrine is a second-line agent that is given in doses of 5 to 10 milligram. It causes the release of the body's own catecholamines. It causes tachyphylaxis, which means that you have to keep giving bigger doses to reach the same effect. You will also reach a stage where the drug no longer works because the body's own catecholamine stores are depleted. Ephedrine is also a second-line drug, and the dose is 1 to 2 milligram every minute until the patient is normotensive. Diluted adrenaline is used for severe hypertension or a high spinal. 1 milligram is added to 200 ml normal saline, and 2 to 5 ml of the solution is given to increase the blood pressure. How to perform a spinal block. Blood pressure, SATs and ECG should be connected before you start any anesthetic, and the values should be recorded. Large bore IV access should be established with an 18 gauge or a green venous cannula. In a bleeding patient, 2 large bore IV lines are needed. A co-load of Ringer's lactate is started before and during the spinal. A prophylactic phenol infusion of 25 to 50 mics per minute can also be started. Remember to give prophylactic antibiotic. The best position is to have the patient sit on the theatre bed with the legs off the bed and feet resting on a chair and bending forward. Some useful tricks are to give her a pillow to hug or to tilt the bed slightly towards you so that she is forced to sit forward. The injection point is determined by using the following landmarks. Draw a line between the 2 iliac crests. If the line passes through an interspace, go 1 space lower. If the line passes through a spinous process, go 2 spaces lower. Give subcutaneous lignocaine at the space and 1 space lower. It is a completely sterile procedure, as the needle will come into direct contact with the central nervous system, where infection will be devastating. The anaesthetist must perform a full surgical scrub and don a sterile gown and sterile gloves. The patient's back is cleaned with 0.5% chlorhexidine in 70% alcohol. The solution must evaporate by itself, about 2 to 3 minutes. Once completely dry, the area around the insertion point is wiped to remove any alcohol or chlorhexidine residue. Both alcohol and chlorhexidine are toxic if introduced into the central nervous system. Drapes must cover the iliac crests and the buttock. The needle and syringe must not come into contact with the cleaning solution, as both these agents are neurotoxic. The smallest pencil point needle is used. The introducer is inserted at the identified space. The needle is then passed through the introducer until a small pop is felt. When the stylet is removed, clear CSF should spontaneously appear in the needle hub. If CSF is not coming back, the stylet is reinserted and the needle is advanced or redirected. If a cutting or quinky needle is used, the bevel should face sideways until CSF is encountered. The bevel is then turned upwards before injecting. When the needle is in the intrathecal space, the syringe is connected to the needle and negative pressure applies to the syringe. If CSF is aspirated, the needle is in the correct space and the local anesthetic can be slowly injected. If there is CSF backflow but no CSF on aspiration, the needle should be advanced a little bit and tested again. Stop injecting if the patient has paresthesia or pain that radiates into the leg. Remember not to inject if the patient is having a contraction. After injection, remove the needle and syringe and observe for bleeding. Cover the puncture site with a sterile dressing. The patient must lie down immediately with a wedge under the right buttock and slightly head up. Blood pressure must be measured every minute. Keep a finger on the pulse the whole time until the blood pressure has stabilized. The blood pressure machine will keep cycling if the blood pressure is too low. A low volume pulse and tachycardia are both indicators of hypertension, and vasopressors should be given without delay. The chart can only be completed once the baby has been delivered, the bleeding is under control, and the mother is stable. The spinal level is tested by using soft cotton gauze to test sensation. The motor block can be tested by asking the patient to lift her legs. A sensory level of T5 is needed before surgery is allowed to start. Spinal anesthesia failure can be either complete or partial. Complete failure of spinal anesthesia is diagnosed if no block has developed after 20 minutes. In an emergency cesarean section, the spinal can be repeated at one space lower than the initial block. The risks, however, include a high spinal or catastrophic hypertension, so always make sure that vasopressors are ready and that IV fluid can be given quickly. In an elective case, or a case where surgery can wait, it will be wise to bring the patient back for a cesarean section later. An inadequate block before or after surgery has commenced is best managed by converting to a general anesthetic with endotracheal intubation. If surgery is prolonged, the spinal may start to wear off. Management of pain at this stage includes systemic opioids or ketamine in analgesic doses of around 0.25 mg per kg. If the peritoneum is closed already, the surgeon can inject a local anesthetic into the various layers. The local anesthetic may need to be diluted to avoid toxic doses. A general anesthetic can be done, especially if the surgery is not almost completed. It doesn't make sense to give sedation to a patient that is experiencing pain. Sedation in pregnancy can easily result in loss of consciousness and will predispose the patient to aspiration. Documentation of the entire anesthetic procedure and the patient's vital signs and reactions are mandatory. It must be clear and legible. The date, time and place must be noted. Patient's details must be on the document as well as the names of the anaesthetists and surgeons. The surgical procedure and the indication for surgery must be noted. Finally, it must be signed by the anaesthetist, followed by the name and qualifications in block letters. Only stable patients must be admitted to the recovery room. If there is no recovery room, the patient must be recovered in theatre. Unstable patients should not be extubated. They should either be kept in theatre until they are stable enough to be extubated, or they must be transferred to an intensive care unit. The blood pressure and arterial saturation should be monitored in the recovery room and documented every 5 minutes. There should also be monitoring for bleeding and nausea and vomiting. The patient can only be discharged back to the ward if her vital signs have been stable for at least 20 minutes. There must also be a documented reduction in the height of the block. The anaesthetist remains responsible for the patient until she has fully recovered from anesthesia. Do not leave the theatre complex until the patient has been completely stable and not bleeding or vomiting for at least 20 to 40 minutes. Once the patient is in the ward, the vital signs, urine output, and pad checks are done according to the ESMOE schedule. Any patient who had low oxygen saturations intra-op should have supplemental oxygen and require saturation monitoring in addition to determining the cause of the low saturation. Regression of the block should be monitored and documented. The block must be completely resolved within 6 to 8 hours. If there is still a dense block after 6 hours, the patient should be transferred immediately to a facility with access to MRI and neurosurgical services. The transfer must occur rapidly as time equals neurological function. Ideally, a hematoma should be evacuated within 8 hours of the initial lumbar puncture. Take-home message. Give a spinal anesthetic because it is the best option for the patient and not because it's the only anesthetic that is on offer. Know the contraindications to spinal anesthesia. Hypertension is common and the blood pressure should be monitored every minute for at least 15 minutes after the last acceptable reading. Vasoconstrictors and IV fluids are the mainstay of treatment of hypertension. Strict sterility is necessary. A level of T5 is needed before surgery can start. Pregnant patients are at risk of aspiration and sedation that leads to loss of consciousness, or a general anesthetic without an endotracheal tube is not acceptable. For more information on spinal anesthesia, please refer to the lecture notes. Thank you.